everyone. Good afternoon. We're about to be joined live by Dr. Akopians from SCRC Fertility. She's going to be speaking to us today about the difference between letrozole and Clomid in a IUI cycle. And she is about to join us. Give it a second. There we go. We're about to be joined by Dr. Akopians. Perfect. This time it worked. I think my internet was not stable. Apologies for that.
No problem. I thought it was from my end, but technical difficulties. Anyway, we're here.
My Wi-Fi is, it has fun sometimes.
Sure.
So how are you? Thank you so much for joining us today.
Of course, thank you.
Yeah, we're excited to learn a little bit more about the difference between letrozole and Clomid. But before we even get there, I want to take a minute to allow you to introduce yourself to the HTICVA community.
Sure. My name is Lena Akopians. I'm one of the board-certified reproductive endocrinology and fertility doctors here at Southern California Reproductive Centers. We're a group of 7 physicians here, and our office and clinic is here more than 22 years. So we're very excited to be able to help our patients achieve their family planning goals. A little bit about my background: I have both PhD and MD training. And so it's been a long journey to get here, but excited to be helping all of our patients in achieving their family planning goals.
Wow. Well, thank you so much for being here with us and for everything that you did to help the fertility community through your education to help better our lives in the process. And I thank you so much for speaking to us a little bit about letrozole and Clomid today. I know that it is something that a lot of us have encountered in our fertility journeys, but I don't know that we know so much about them and their differences. So let's begin basic. What are the foundations of the letrozole and Clomid drugs, and understanding a little bit about their differences?
Sure. I'm going to go but one step even before that and talk about what do we need to be able to ovulate, right? There is hormones released by the brain, and those hormones communicate with the ovary, and they dictate the ovary every month. Enlarge an egg or a follicle, get it to maturity, and then release it. And once it's released, now that egg can see the sperm, hopefully create a pregnancy if we're trying to get pregnant. So in some women, they don't ovulate, and that's specifically one category of women who don't ovulate. They're diagnosed with a condition called polycystic ovary syndrome. And they have all the right hormones in the right places, but that communication is not done as effectively, and therefore women don't end up having regular periods because they're not ovulating. But what are those hormones? The one that causes the follicle or the egg to grow, it's called follicle stimulating hormone. FSH is a short. And that's the one that is responsible in telling the ovary to enlarge and release an egg. Now, letrozole and Clomid are 2 agents that are pills, basically. They're just medications, and they help women who don't ovulate, such as women with diagnosis of PCOS, to ovulate. And their mechanism of action is slightly different, even though their end product is the same, which is make somebody ovulate. And so what both of them do is sort of trick the brain in thinking there's not enough estrogen in the body, and therefore the brain says, oh, I need to work harder. I need to produce more FSH. And as such, therefore, get someone who's not ovulating into an ovulatory cycle. And letrozole does that by inhibiting a specific enzyme in the peripheral area of the body called aromatase. And therefore, the body thinks there's not enough estrogen. And Clomid does that more directly by attaching a receptor in the brain area and faking the body and thinking there's not enough estrogen. End product of both is still the same. They both increase the FSH level in the body, and the FSH then gets someone who's not ovulating into an ovulatory cycle. So that's sort of the basics of the 2 medications.
Wow. Thank you for explaining that. So being that they both come to the same end product of getting a person to produce more FSH and then ovulate, what would make one patient be prescribed letrozole and another be prescribed Clomid?
Mainly a research that was published a few years ago that head-to-head looked at both. Clomid had been around for many, many years, decades, and was being used. And then came along letrozole a little bit later as a treatment in a breast cancer situation where they then noticed, oh, it causes women to actually have ovulatory cycles. So then the research ended up taking a look at both medications head-to-head, and took about 750 patients, randomized. Here's a group that's going to get Clomid this month. Here's a group that's going to get letrozole. What was the end result? They saw that letrozole did better in ovulatory cycles and pregnancy rates in women with diagnosis of PCOS. So now the first agent to go to, because of that particular study, is the letrozole to cause patients to ovulate with a history of PCOS. Now, in what situation would we look at patients taking Clomid? We get situation of what's called unexplained infertility, right? These are couples that have been trying to get pregnant. They can't get pregnant. We've done all the workup. We can't figure out what. They have enough eggs. They ovulate. There's plenty of sperm. The uterus looks good. The ovaries look good. The fallopian tubes are fine. Everything is perfect, but they still can't get pregnant. In such women, we may utilize Clomid to make them super ovulate. So rather than an induction of ovulation in women who don't ovulate, but rather people who are normally ovulating, maybe we want more than one egg released. Therefore, increase the chances of the egg and the sperm meeting each other. And that's when we would utilize Clomid, for example.
Amazing. So I know that you addressed with PCOS that letrozole has a higher rate of success. For an individual who does not have a PCOS diagnosis, is there a difference in success rates between letrozole and Clomid?
No, if somebody doesn't have PCOS diagnosis and they tend to regularly ovulate, probably utilizing Clomid to super ovulate them would do a little bit better because more than one egg would be released. But they've been pretty equivalent in successes when research has looked at them.
And for someone who's not having success with Clomid, is it normal to then try letrozole if they do not have a PCOS diagnosis?
It depends on if they're being followed with their ultrasounds and being monitored. And I say that is because with a certain percentage of the population taking Clomid can actually negatively affect the lining of the uterus. So if you took Clomid and now you have your follicles, but your lining looks thin, there's probably not going to be successful pregnancy. Letrozole doesn't have that negative effect on the lining. So if we know we gave somebody Clomid and that lining ended up being thin, we would switch to, for example, letrozole. If the cycles are not monitored, meaning they're being given by OBGYNs, for example, and they're not monitoring the lining, that's a portion that we would never know about. And they may flip back and forth between the treatments.
And then how many cycles would be what you would recommend of either letrozole and or Clomid before one says that this is not the correct treatment, let's move on to the next?
So when you look at research, 90% of couples, if they're going to get pregnant with these types of treatments in combination with IUI, they usually do so within the first 4 cycles. So we're 4 months of trying. You can go up to 6 months, but that 6 months is really the cutoff where we say if we haven't been able to get you to a pregnancy, there may be more to the story. And therefore, then we would say more advanced treatments is the way to go.
And when you say 6 months, does that mean 6 months of consecutive treatment cycles or 6 months with some of them being treatment cycles?
Mostly when patients come to us, they've already been trying about a year on their own, right? So if you've tried a year on your own, and whether it's successive 6 months or you skip the cycle in between, that already is a situation of infertility. And so women's age also makes a very difference on how long you want to do these types of cycles before you go on, right? If we have women in their 40s, we may say we may not want to do all full 6 months. We may want to do a few trials. If we're not successful, then we move on with more aggressive treatments.
Amazing. Thank you so much. Thank you for sharing all this information and for taking a real deep dive with us today into letrozole and Clomid. I know that so many of us will benefit from having this knowledge. Before we end this live, what's one thing you'd like to leave our community with?
So I always say knowledge is power. So make sure you're partnering up with a physician who's your advocate, who's going to educate you and be on your side in being able to come up with the best treatment option and get you ultimately the end goal.
Amazing. Thank you so much, Dr. Akopians. We so appreciate you taking the time to join us here today and to speak about the difference of these two drugs, and have a wonderful day.
Thank you so much for the invitation. It was a lovely conversation. If I can help anyone in any way, please let us know. And it was lovely doing this.
Thank you so much. And we'll make sure to tag you so that people can reach out.
Sounds great. Have a wonderful rest of your day.
You too. Thank you.
Bye-bye.